Welcome everyone to today's program. I'm Shannon Barnett with Becker's Healthcare. The program will begin with a presentation and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during this time. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenter. Ms. Dice is a graduate of Luther College, Northern Illinois University, and the University of Illinois Chicago. Lori Dice evaluates learning needs for AAAHC surveyors and accredited organizations and designs educational programs and products to meet them. Most recently, Lori has developed a set of quality improvement tools that are taught at AAAHC Achieving Accreditation seminars. She serves as a facility lead for quality improvement in education for the AHRQ HRET safety program for ambulatory surgery and as an adjunct professor at Elmhurst College Deak Center for Nursing. Prior to joining AAAHC in 2013, Lori worked in clinical and educational settings where she combined analysis with creativity in designing and delivering simulation-based education for diverse healthcare organizations. She has over 25 years of nursing and education experience, including high-risk obstetrics and public health nursing. It is now my pleasure to turn the floor over to Lori to begin today's presentation.
Thank you so much. As it was said, I'm Lori Dice. I'm the Assistant Director here at HHC. And today we're going to talk about linking peer review to benchmarking to improve quality in your organization. So you may, next slide, please. And next slide. So these are today's objectives. This topic is a topic that many of our organizations seem to have trouble with. I think there's many pieces to the process, and so what I'm going to try to do today is really simplify this process and kind of break it down so that each piece of kind of this working puzzle is tangible and that each piece is and makes sense to folks, because with peer review and how do you determine quality improvement or how do you integrate it into privileging, it becomes very overwhelming for everyone. So today we're going to talk about describing the process for establishing criteria for peer review, analyzing the results of peer review using internal and external benchmarking, develop QI studies based on peer review data, and then incorporating peer review into the process for granting continuation of clinical privileges. Next slide, please. So peer review seems to strike the fear in the heart. But it really is simply another method of data collection. Having a program or process to systematically collect and use the data can be extremely beneficial to organizations. And at times, organizations will be collecting data, but the data may not be evaluated or acted upon. Once the peer review data is analyzed, organizations can identify and address organization-wide performance issues that are we know as quality improvement studies, or help identify individual outliers. So let's talk about the outliers for a little bit. Outliers are just that. They fall outside of the expected performance, and we see outliers as either positive or negative. Outliers that shine above and beyond can be role models for best practices, and outliers that fall below the expected performance can be addressed individually to find solutions. The organization's peer review plan should include steps to take an event of a physician-specific performance problem, and certainly that should be made in consideration when you grant for privileges. So the benefits of peer review is comparing performance, as I said before, identify variation in performance and identifying the outliers, system-wide issues, and then we want to drive appropriate interventions and then establish criteria for granting or denying those privileges. Next slide, please. So this is a process cycle that I developed just to help organizations kind of understand all the pieces, as one could say, to the pie that makes this complete circle. The diagram shows an overview of this process. of linking peer review into benchmarking and then developing quality improvement studies that may result from this. So the first thing we want to do is establish what is the criteria for peer review, collecting and analyzing that data, comparing the performance, and then developing quality improvement studies, and also looking at any provider-specific intervention that can be used when we grant those privileges. Next slide, please. So we're going to begin with the first piece of this kind of circle. Healthcare professionals participate in the development and application of criteria used to evaluate the care that they provide. I think this is where we begin, and this is the organization's starting point, but what does this actually mean? For example, if peer review is going to be completed on physicians, the organization will need input from other physicians in the development and selection and approval of this criteria. And what's really important that we develop meaningful data. Many organizations, their peer review is just a chart audit, but you really need to look at data that's going to give you a robust understanding of how that physician can perform. Next slide, please. So considerations. Here are a few things to consider as your organization begins their data collection process. How is peer review currently conducted? Who is included? Is it your physicians, your dentists, or other healthcare professionals, such as nurse practitioners, nurse anesthetists? Is the peer review performed by at least one similarly licensed peer, such as is a physician peer reviewing another physician? Is the data used to monitor important aspects of care provided by the organization, and is the organization collecting the data for the purpose of what? It has to have a meaningful reason to why you're collecting this data. Is the data regularly being evaluated to identify trends, outliers, and organizational problems? Hopefully these components are already addressed in the organization peer review policy and plan that you already have. Next slide, please. So now let's talk about the development of organization criteria. As we said, we require input from participants, from those who the performance will be reviewed. We need to align it with your peer review policy, and you need to look at existing data. So this is the biggest misnomer out there. People are collecting all kinds of data on their physicians, so you need to pay attention to what you're already collecting, why you're collecting, are you collecting the right things to really evaluate your physicians. Identify and add any physician performance indicators. Ensure that your data is valid, comparable, and also consistent. Next slide, please. So in addition to key performance areas, or data collection is developed to look at your organization goals, and these are your missions and values. So the data you collect should somehow align to the mission, values, and goals of your organization. You need to look at the services provided. If you're a multi-specialty ASC, you need to look at anesthesia services, surgical services, and then break those even down further. If you do ophthalmology, you do ortho. So you really need to look at all the services that you provide. You need to look at state and regulatory requirements, and specifically regulatory requirements, you need to look at CMS. Also, review the organization's other programs, such as infection prevention control, risk management, and safety programs, if there's other items within those programs that might derive some data that you need to collect on your providers. For clinical outcomes, you may want to refer to your specialty organizations. Each specialty usually has some type of specific benchmarks related to the services. For example, one example would be the American Society for Gastrointestinal Endoscopy, ASGE, has a registry of benchmarks that physicians can compare themselves against. So you need to keep in mind is what measures are most important to the physicians and to the governing body, and are the identifier indicators actionable? Can we fix any problem that we may see? Next slide, please. So what are key performance indicators that we should take a look at? The first one would be complications, and this certainly depends on the organization, and this could be medication reaction, post-operative infection, return to surgery, ER visit, supply of cost and medication costs. Compliance relates to compliance to screening guidelines or best practice guidelines. Timeliness can relate to on-time visit, on-time starts, things like that. Efficiency is the length of the visit, the procedure, the surgery. Documentation, is it legible and is it complete? Most of us have an EMR system that we work on, but we want to make sure that it's complete. And then utilization may be related to tests or medications that may be ordered. When you define your key priorities for high performance, you want to make sure that you kind of prioritize what is most important to both, as I said before, the physicians and the governing body. Next slide, please. So once you've identified what you want to, what data you want to collect, it's time to go out and actually collect that data and begin to analyze that data. So the data related to the established criteria collected in an ongoing manner and periodically evaluated to identify acceptable and unacceptable trends or occurrences. Here at HHC, we don't really define what periodically evaluated, but for some organizations and for some of the metrics that you're collecting, it may be on a monthly basis or maybe on a quarterly basis, but you have a timeline that you would like have established, and it may be different for different types of criteria that you're looking for. Next slide, please. So these are a couple different ways of data collection methods. A retrospective study is looking at past data, and I would say this is probably what a lot of people do is they use a chart audit tool. They have certain criteria that they're looking for. So if the organization has an EMR, it's very easy for the organization to abstract data. This can be incredibly useful in collecting and filtering the data efficiently. Using a chart audit tool may be a good place to begin, but it's really important to keep in mind that incomplete or inconsistent chart documentation does pose limitations. And keep in mind, this might not be the only method of collecting data for peer review. A perspective is using collected data to help predict what the future may look like. Based on what we see today, this is probably what we're going to see next month or next quarter. And so you use this information to kind of plan what your next steps are going to be. Real-time data is collecting time. The organization may want to collect real-time data, and this could be accomplished via a customized data collection tool. So you collect the information now, and you can make the changes based on what you're seeing right now. So that's through the form of a survey, might be an example of how we might do that. And observation is actually direct observation. So there's a lot of data through observation that you cannot collect using a chart audit tool. This may be a way the provider communicates with the staff. How do they do their timeout? Are they following manufacturer recommendations on equipment? And these are really important factors, safety and quality issues that you would miss through a normal chart audit. So observation is another way of looking at peer review. Next slide, please. So displaying the peer review, once you've collected all the data, a format designed to compare individual performance with the organization and each other. So this is a great at-glance way to look at how are all your physicians kind of stacking against one another. And in the surgical world, it's most often called a scorecard. It's very useful for visualizing peer review and demonstrating opportunities for improvement. Physicians tend to be very visual folks, so it's really easy to take a look at the data when it's in a more of a visual form. Next slide, please. So here's an example of a surgical scorecard. This is the same. This is just a quick example where we kind of stack the providers against one another, and we see. I made this data up. So these are things that were criteria that we're collecting on each of the providers. And keep in mind that with a lower volume of physicians, a percentage score may not always be the best way to present the data. So you do need to look at what is your N. So for example, if you had 6 cases, but one had an SSI, this would result the provider would have an SS rate of 17%. So you need to keep in mind what is your N number when you're starting out with, and what is the best way to display that data, whether it is in percentages or raw numbers. that we're not skewing the data. Next slide, please. So the organization implements a data collection process to ensure ongoing quality and to identify quality-related problems. And so the first thing we need to do is analyze the results of the peer review activity. And we'll go to the next slide. Peer review data is analyzed for overall performance as well as each physician's performance. So we're taking a cumulative of each physician's performance, and that's what we call our current performance. But we also want to look at each physician's performance to see if someone really skewing the data, is someone exceptionally high or exceptionally low that may be skewing what our current performance actually is. And again, it's a very easy display of current performance using the scorecard to provide a visual. So we'll take a look at the next slide. Okay, and so here's an example where we have all the providers listed, and then we also have taken a look at the current performance. The current performance is the average of all the providers together, and you can see that by looking at this, we can internally benchmark our providers from one to the other. If we look at patients receiving antibiotics for 1 hour, you'll see that Dr. A is 75%, but everyone else is at a more elevated rate. We'll go on here in a little bit and talk about how we still need to set a performance goal to decide on is only one provider out of compliance, so we'll do that in the next slide. So when we go to the next slide, and so in order to see where our current performances in each individual provider is, we really need to establish what is the benchmark we're trying to achieve, and can we go ahead and adopt that benchmark as our actual performance goal. And we can derive a performance goal from either an internal or external benchmark. It's also important that data cleansing may have to occur. So you need to take a look at the data that you have when you establish your current performance to decide do we need to remove some of the data in that database because it's not correct or it's incomplete or it's just not giving us what we're really asking for. But once the data has been cleansed, then you'd be ready to take a look at the benchmarks and establish that performance goal. So we'll go to the next slide. So let's talk about what is benchmarking. So benchmarking is a comparative best as a baseline for improvement. It identifies best practices which become the benchmarks against which others are measured. Now, not all data can be benchmarked. And what I like to say to organizations, it's best to look for an external or an outside benchmark, one that you found in the literature, one that your society has told you is the best benchmark. But in some situations, internal benchmarking may be the only way we can derive a performance goal. How did we do the month before? How did we do the year before? Are we still in alignment to where we were before? But we use these benchmarks to help us decide on setting performance goals. Next slide, please. And this is a little bit more on internal benchmarking. Again, this is comparing the performance within an organization such by a physician or department over time. Again, look at month to month, provider to provider, department to department. And at HHC, we do require organizations to both look at internal benchmarking as well as external benchmarking. Next slide, please. This is comparing the organization's overall performance to that of individuals' performers. So compare your best performer to your lowest performer. And what you're really looking for is what is the variance. If you have someone that's scoring 98% on their patient stat and you have someone else that's 27% on their patient stat, that's a huge variance. What is going on there? Identify trends in the data. Have you seen from quarter to quarter or month to month that your patient satisfaction is starting to go down, but and then all of a sudden you have some new providers that have come on board. So you need to start looking at the trends in your data and start to figure out why are these things occurring, and do we care? Most people do care if the patient satisfaction trend starts to go down. Use a performance goal to identify outliers and also to identify system-wide problems, and I'll show you that in the next few slides. So go ahead, next slide. So here is, again, we're using the same surgical scorecard. The green indicates my high performance, the red indicates my low performance, and so I'm starting to see that on on-time starts, while my lowest performer is 45%, I look at the current performance at 67%, it looks like we may be struggling across the board on that, but it's really hard to tell until I set a performance goal to that. You'll also see on comprehensive H&P, are all over the board. You have people that are 100% on making sure that H&P is available for when they start the procedure, but then you have Dr. B who's only 27% compliant. So we need to kind of figure out with both our high and low performers, why are our high performers so high? What are they doing that's helping them achieve the high score? And what are our outliers or low performers doing or don't have that's causing them kind of to perform low and then skewing the overall current performance? Next slide, please. So what we need to do is to help really define what is going on with the data is we need to set a performance goal. And again, it's best practice to benchmark. And we encourage an external benchmark, but sometimes that's not available. And so you can look at your internal benchmark. But what a benchmark does, it provides a rationale for the performance goal rather than just a random selection. Again, as I mentioned before, a benchmark is not always applicable. One of the things we like to encourage here at HHHC is to use what we call a SMART goal. So the S starts for we make sure that the goal that the performance goal that we're setting is specific to what is being measured. The M means that it has to be quantitative. We cannot use words like we would like to decrease the wait times or the start times, because when we go to compare it to the current performance, we're going to have a lot of difficulty comparing the word decrease to a certain number that they may have. So we actually have that in our standards. It has to be quantitative. Achievable. This is where an external or, in some cases, an internal benchmark is very crucial to establishing that realistic goal. What happens is organizations tend to overshoot the goal. I call it an absolute goal. They'll say we want to be absolutely 100% compliant with our start times less than 10 minutes from the time of when we plan to start or something like that. Most cases, 100% is not applicable. If you're talking about things like sterilization and disinfection and you want, biological indicators or something related to that, that is a high safety event. Those have to be 100%. But most of the things we're looking at are not 100%. In fact, we're going to set ourselves up for failure if we put 100% for everything that we want to do. We also set a benchmark because we don't want to undershoot. We need to look at what other folks are doing as far as in this area that we're studying, and to make sure that we don't set our goals so low that we don't think we have them. The R is the relevance, and this is really important. This is the significance to the organization. This is the meaningful part. This should have a lot of meaning to your organization, and this helps create buy-in to why you're even working on this performance goal. And then I personally like time-bound, and this is actually a date that you plan on actually achieving this. So if it's 12/31 of 2016, and so what it does is it helps me create a timeline to when I need to complete this. So if I want to complete this goal by the end of the year, I have to have time to collect my data, decide that I have an issue, and then go ahead and implement the corrective action, and then remeasure my data, and then report it out to my governing body. It helps me kind of create a calendar or timeline up until that time where I want to achieve my goal. Next slide, please. Okay, so now we're adding on to our surgical scorecard, and you can see here that we went ahead and developed performance goals based on benchmarks. Now, for the purpose of this lecture, I have made up the data for this slide. So if you ask me, where did this all come from? The slides were, it's just been kind of fabricated for the purpose of showing you how to do this. So you can see here we added the performance goal. And so if we go to the next slide, once we add the performance goal, our data starts to make sense to us. So we can see here on SSIs, when we add our performance goal and we look at our overall current performance and all of our providers, we are very compliant here, and our providers are doing a great job. We do not really have an issue. Our overall performance is exceeding what the performance goal is. Each of our providers are in compliance, and we were actually really doing a great job with surgical site infections. When it comes to patients receiving antibiotics under 1 hour, we can see that the performance goal we wanted to hit was 90%. Our overall performance was 91%, so as a group of providers, we did really well. We have one provider, though, Dr. A, who's 75% compliant. So we need to take a look at why is Dr. A 75% compliant? Is it his fault? Is it some other circumstances that has been his fault? Do we have a low number of cases? So we need to figure out, is this 75% truly reflective of the care that's provided by Dr. A? And if it is, then when we go to grants and privileges, we will need to address his patients that he's lower than all the other providers and under the performance goal we want to be. That should be taken into consider when we grant him privileges. On-site start times, we can see that when we put the performance goal together, we can see that our overall performance is much under the performance goal we want to be in, so we have a quality improvement study. We have a system-wide problem, and so in this case, this would be a quality improvement study where we need to fix the entire process to achieve a better outcome on-time starts. You can also see that you do have someone who's scoring 78% and someone who's pretty low in 45%, but I think it's worth kind of thinking that the process of on-time start, we have a kind of a broken process, that the whole organization would be better looking at that as a problem as a whole. And so that would lend me to think I need to do a quality improvement study on this area. Timeout, again, timeout is one of those that should be 100%. In most organizations, this is a never event. If a timeout was not performed, some people could get fired for their job. So we see here that the data has been skewed by one provider. Again, if you're starting to see a trend, Dr. A is slowing, he's lowering the overall outcome here. He's 75% compliant, whereas everyone else is 100%, and that's what we want to be. So we need to take a look at what's going on with Dr. A, and again, when it goes to granting his privileges, we need to come up with some provider-specific intervention to how we're going to increase that. Comprehensive H&P, we're kind of all over the board. We have people that are 100% and then people that are extremely low. And in this one, you can see the overall performance is 63%. Now, we could do a complete quality improvement study if we feel like we have a broken process, or in this specific situation, because these some providers scored so high and others scored so low, we might want to look at provider-specific reasons to why the H&P is not available when these providers perform their surgical procedures. Okay, next slide, please. All right, so as I already kind of discussed, once you have your current performance and overall in an individual provider, you need to use a benchmark to set that performance goal. Once you have defined the performance goal, then you're ready to solve the QI equation, and it's a pretty simplistic equation. If your performance goal is greater than your current performance, then you have a quality activity. If that performance goal is less than your current performance, then you either have a quality improvement study if all the providers are out of compliance, or you would have a provider-specific problem if there's only a few that are out of compliance. So we'll show you the next slide. Okay, so we talked about quality activity. The organization's overall current performance meet or exceed the performance goal. No corrective action is needed for the organization. And I say to you guys, you're doing a great job. This is fantastic. Now, the question we get at HHC is, well, how long do we have to monitor this data? And then we kind of give the answer, well, it really depends. It depends on, is this data that you have to collect for CMS? Is this a data that you have to collect for HHC standards? What is the driver to why you're collecting this data? Is this data, if you don't watch it, you will notice that there's a decrease in the overall performance. And also, it depends on how have you hardwired this great performance that you're seeing. How have you hardwired so it occurs every time? Do we have a policy that says that they have to follow a certain actions that help increase this performance? So it really depends on, is it a metric that you are required to keep track of, or is it something that you have a hardwired policy that if we stop watching it for a year and come back to it, we can guarantee that the performance will remain the same? So it really, it's dependent on those factors. Next slide, please. Okay, so using peer-reviewed data for improvement. So we discussed our options for improvement. We talked about a quality activity. We talked about a system-wide improvement needed using a quality improvement study. And then we also talked about provider-specific interventions if you need that. So if you go to the next slide, as we talked about, SSI is an example of a quality activity. And everybody met the performance goal, our overall current performance met the performance goal. And again, but this is something that we can't just say, okay, we're doing really well on this. We need to stop looking at. This is a metric that we need to continue to be monitoring. So because of the importance of it, and it's a CMS requirement. Next slide, please. So quality improvement. Again, we talked about if it's a system-wide problem, then we're going to attach a quality improvement study to this. This means we need a corrective action that must be implemented that addresses the source of the problem. And then once we implement the corrective action, then we need to remeasure, and a remeasurement is required to see if the corrective action worked and if we met the performance goal, or at least saw an increase going towards that performance goal, but we would like to optimally meet that performance goal. So that would be a quality improvement study. So next slide. And as you can see from our data here on-time start times, for sure we have a quality improvement study. Comprehensive H&Ps, you can do a quality improvement study here. The current performance did not meet that performance goal, but we can see we have some real outliers that skewed that data. So on that one, it would be dependent on what I would probably do is I'd implement a quality improvement study, and I would adapt some of the processes that I saw going on in Dr. A and Dr. C. Next slide, please. Okay, so here at HHHC, once you have a quality improvement study, we require every organization that's going through the application process for accreditation, initial or for reaccred, that you submit two studies to us, but one needs to be a completed QI study. We would like you to document that QI study, and we use what we call the HHHC QI study template. But we don't require that you have to use our study, but we do require that it has elements of the study within it. So when you write up the QI study, you have told us what the purpose of it, why it's significant to your organization. You wrote that performance goal that's probably hopefully based on a benchmark. Describe how you collected the data, what are you collecting, who's collecting it, how are you collecting it. You show us evidence of the data. You analyzed the data, comparing the performance goal and the current performance, and telling us, once you compare it, did you have a QI study? Did you have a QI? In this case, you'd have a QI study. You did not meet your goal, and so you're going to implement a corrective action, a remeasurement. If you did not meet that goal, then you have to initiate another corrective action with a remeasurement, and then you need to report it out to the governing body. Now, we do require you to address the 10 elements, but 5.1c is only if needed. So that's kind of an exception to that rule. Next slide, please. If it's a provider-specific intervention, this is important for granting privileges. If you identify an outlier, then you need to make sure, sometimes being aware will fix the problem. That's why I like scorecards. I think it's a great way to make immediate change when they're very competitive folks. So when you start kind of showing how they fit into the overall picture, and they see that they're the outlier pulling people down, sometimes just that awareness will fix the problem. You want to ensure data collected on physicians is comparable data to others. So, for example, you don't want to compare the surgical site infection rates of a plastic surgeon to an orthopedic surgeon. That's just not comparable data. You want to assess the source of the problem. You want to make sure, is the problem the provider, or is it the surgical tech working with them, or is it some other issue? Is it that this person has complicated patients that no one else has? You want to involve the physician in the solution and intervention. Do you have all the tools you need to fix this problem? What can we do to help you? And then you want to remeasure that performance after the intervention. Now, some people, when they go to grant privileges, depending on what the issue may be, may put them on a corrective action and give them a time period that that particular, issue is not fixed. It may even temporarily suspend their privileges. That would be the worst case scenario, but that's kind of how you may want to use, you could use that data when granting privileges. Next slide, please. And here we've talked about who are outliers here and who needs a little fixing. So next slide. And again, I just reiterate the results of peer review should also be used part of the process when granting privileges, because really the peer review is kind of it's really their performance evaluation. And if you have a consistently low performer, an action plan may need to be implemented. If you have a consistently low performer, as we kind of saw in the scorecard, physician A was low in 3 areas, you need to kind of start to decide after a while, is this a person that you want at your organization, especially if they're not willing to improve their performance. So that's kind of how peer review works with granting privileges. Next slide, please. Oh, and this is AAAHC's Achieving Accreditation Conference, and if those of you who are listening today are AAAHC organizations, or if you're thinking about becoming a AAAHC organization, we hold quarterly conferences, and our next one is going to be June 10th and 11th in San Diego. And if you need more information, you can just go to www.AAAHC.org. And then the next slide is I'm actually ready for questions if anyone has any. So I'm going to just kind of take a little peek here and okay, we have questions up here. So this question is actually for Emma or Caitlin from Becker's. They want to know, will the slides and the recording be available in the future? Emma or
Caitlin?
We're
happy to answer that. Yes, the slides and recording will be sent out about a week following the webinar. So you can look for an email from one of us at Becker's Healthcare about a week following. So we'll make sure that gets to your guys' inbox.
Okay, great. And let me just, give me a second here. I'm just going to kind of take a look at your questions.
Lori, thank you very much for an informative, enjoyable presentation. Everyone, just a reminder, if you have any questions, you can type them into the control panel in the space labeled Enter a Question for Staff and clicking Send. We'll get them right away.
Okay, so I have a question here, and this is actually a great question. The question is there such thing as an internal benchmark when you only have one surgeon in your surgery center? Actually, that's a fantastic question, and the answer is yes. You can compare there's a couple ways he can compare his performance from month to month, however you collect the data for him, but he can compare his own performance against himself. So that can be from month to month, from year to year. That's a way that he can go ahead and internal benchmark against his own self. Okay, so here's a question, and I'm going to attempt to answer this. The speaker noted that an organization needs high-quality data on which to base peer review and quality improvement. Do you have any specific suggestions to improve an organization's data quality? What do you see organizations doing to build trust in their data so providers will take the data seriously? This seems to be a big problem or big hurdle in many organizations. You are right. That is, you're not alone with that. What happens, what I see in peer reviews, the data is kind of weak. A lot of it is they're collecting data on chart audits. So I think there's a couple ways that you can kind of drive that data. One, it does begin with the medical director, but then some of you may be thinking to yourself, well, the medical director is the problem. The one way that you can start with collecting some of that data is look at what your state's requiring or what CMS is requiring that you have to collect data on. Also take a look at it if you are accredited organization, take a look at where you struggled last time with some of the standard deficiencies, and that might help generate some data to what you might want to base peer review on. But remember, the criteria that we use peer review for is developed from the physicians. And so you want to go back to those key performance indicators like cost, complications, compliance. Take a look at what those things look like at your site to help to kind of drive some of that data. But you want the data to be meaningful so it does improve the overall quality of your organization. SSI, by the way, is surgical site infections. And that was a question someone had. So the question is, how have doctors react to their data being made available to their peers? So you have to decide on how you're going to do that. I mean, that's just a suggestion. That's not a requirement. But sometimes when doctors see how they perform against their peers and they see that they're a low-lying provider, sometimes that'll make change. Now, again, before you do any display of that information, you would have to do a little data mining to make sure that information is accurately. Sometimes that information may be just shared with the medical director so you can see the overall picture. So you need to be, a little bit selective in how that is going to work in your site. And you may want to present the data a little different, that here's where your ranking is, and here's where everybody else is, and maybe you, but you need to be careful because if there's only a few providers, they're going to quickly figure out who is who. So, but it is important for them to somehow communicate to them how they're comparing to overall in the organization to the specific metric that you're looking for. The question is, do you have a sample template used for peer review for each service? And we do not have a sample template for peer review. And again, I think the reason why we don't is it varies from organization to organization because, again, remember the criteria for peer review is really should come from input from the providers at your organization. So it's going to look a little different from organization to organization. So the question is, they would like to know if I have any examples of QI studies for single specialty ophthalmology center. And I actually do. So I'm going to just give you my email, and whoever sent this question, I'm going to have you email me. My email address is ldihs@hhc.org. And if you can let me know if you're a HHC organization or who you're accredited by, that would be helpful as well. Okay. So So someone asked, do we have to code the physician's name? We're a small organization. I'm not sure that'd be effective. You're right, that might not be effective. You need to be a little guarded when you're sharing this information or how you're going to share the information. But I think how I would start is once you get the information, I would begin that conversation with my medical director and then kind of decide on how this information is going to be relayed. You can make it as simple as, here's what your performance is, this is what the overall organization's performance, here's who my high performer is. So the scorecard is just one way of displaying that data, but it's not always, it may not be the best way for your organization. But somehow you have to communicate to them, particularly if they're a low performer, how they compare to the rest of the group. If you're going to, especially if you're going to use that when granting your privileges, which is a requirement here at AAHC. So a question here is, if an organization has an advanced practice staff, like NPs and PAs, would the process be different? And so then a comparison of physicians would not work. It depends on what the person's doing, but yes, the process, the process for peer review would be similar for APs and for PAs. Again, it depends on if they provide if it's comparable data. If the if it's something to do with wait times, let's say you have a nurse practitioner and she sees patients and you're looking at wait times, and then you're looking at providers' wait times, you may be able to compare some of that data. So you have to take a look to what data you're comparing it to. But you also want to have metrics that are specific to the service that they're providing as well. This question is going to be for Caitlin or Emma. They want to know, is there CEUs related to this?
Yeah, that's a great question. So we actually are not able to give out CEU credits, so we are able to provide certificates of attendance. So if you want to email one of us at the Becker's team, we can definitely get you the certificate in which you can submit independently.
Okay, great. And I think that these are all the questions that are for me today. And I really appreciate all of you. We had a pretty large attendance, so I appreciate all of you taking time out of your day today to listen to this webinar. And thank you.
And on behalf of the entire Becker's team, thank you again, Lori, for your excellent presentation and for taking questions. And thank you everyone else who participated today. We look forward to having you join us for future webinars. This concludes today's program. Have a wonderful evening.